Good morning. Welcome to Grand Rounds. We pride ourselves in this building in providing the most cutting-edge medicine that's possible on the planet. The topic this morning is complexity, and complexity was appreciated long before modern methods became available. And part of what we're going to hear this morning is how incorporating the thinking and principles of those who lived long before us and far from where we are can help our patients in this building in ways that the most modern methods by themselves are not capable of doing. We have two speakers. Our second speaker, Andrew Shubov, was an undergraduate at NYU, and then he came to Los Angeles, and he went to USC's Keck School of Medicine, and then to Cedars for his internship and residency, and then he came to UCLA and the EastWest Center to work with Kit Huey and his colleagues in a fellowship in EastWest Medicine. Our first speaker was an undergraduate at Harvard College, and then she came to Los Angeles and earned her MD from the David Geffen School of Medicine, and then sat in the back row as an intern and resident in internal medicine, moved to the front of the room as a chief resident, and then joined Dr. Huey's fellowship in the East-West Center. Please join me in welcoming Annie Zhang. Annie?
Thank you, Dr. Fogelman, for that kind introduction, and thank you for the chiefs for inviting us to come talk to the group today. So I wanted to start off our talk with a little bit of audience participation. So I'm going to give you a series of signs and symptoms, and I'd like you to tell me what condition I'm describing. So the first scenario is a patient who has been having some blurry vision, a little bit of anxiety, some diarrhea, they've been losing weight, and when you look at the patient, it looks like they have some exophthalmos. So what does this patient have? Somebody shout it out. Yeah, you guys know this. I heard. Hyperthyroidism. Yes, hyperthyroidism, probably Graves' disease. Okay, on to scenario number 2. This is a young woman who comes to you. She says, I've been having fevers, I have malaise, my right side of my back is hurting really badly, and for the last few days, it hurts when I pee. So, what does she have? Anybody? Hylo, probably, yeah. Maybe a kidney stone, or maybe both. And then third scenario. So this is a woman in her 30s who was recently diagnosed, unfortunately, with bilateral breast cancer. And in talking to this patient, we find out that her mother also had breast cancer at a young age. Her aunt had ovarian cancer, and she even has a grandfather who had male breast cancer. So what is this condition? Anybody? BRCA? Yes. Awesome. 3 out of 3. You guys have been doing your mix-out questions. So what do these conditions have in common? Well, it turns out that though each one can present with various clinical manifestations, you can pretty much boil them down to a single pathologic process that's causing it, whether that's an imbalance in hormone caused by abnormal antibody, infection and inflammation in an organ caused by bacteria, or a particular genetic mutation that increases the risk of a series of related diseases. And so these are all actually examples of what we can think of as complicated systems. So what does that mean? Well, the easiest way to explain it may be through another example. So this is the prototype of what is thought in system science of a complicated problem. This is a Swiss watch mechanism. It has a lot of different parts. They all kind of fit together to create the whole system. the effects of the system are pretty linear. So each part has designated roles, and you can pretty much predict what will happen if you change any of the individual components. So, this is the kind of the prevailing view of science for much of the last several hundred years, from the time of Descartes and Newton. And this is also pretty much the way we thought about a lot of modern medical diseases. We look at the process, we break it down into its component parts, and we figure out which areas have gone awry, and then we can go in and target treatments to those components, whether that's a chemical or a surgical procedure or even biologics and gene therapy. As clinicians, we are also sort of generally trained to think in this way. So when we see a pattern of symptoms, we really try to figure out, where exactly is the problem, and then we can usually find some tools to fix it. All right. So while you keep that in mind, I'd like you to help me name another condition. So this is a middle-aged woman who comes to see you, and she's been kind of just feeling a lot of pain for the last several months. She says her whole body aches. Sometimes it's her back, sometimes it's her leg, sometimes it's her head. She has a lot of fatigue. Her cognitive function seems a little bit slow, and she has brain fog. Her sleep has been poor. And on exam, you see that she really has, only remarkable thing is that she has a lot of tender points throughout her various muscle groups. And you send a big workup, all of it comes back negative. What is the most likely condition we're dealing with in this case? Anybody? Fibromyalgia? Yeah, most likely. So compared with those other conditions, how satisfying is it when you sort of make this diagnosis? Probably not as good. And how confident do you feel about going about treating this problem? It's probably a little bit less comfortable feeling. So why is that? Well, it's a little bit difficult to understand the syndrome in the context of a sort of a complicated system where you can kind of pin down on the exact cause and then go about trying to treat it. So despite an enormous amount of effort that's been put into looking for sort of that skeleton key or magic bullet that will fix this, we really haven't been able to very easily. And, the list goes on in terms of similar syndromes that afflict a lot of our patients where there isn't really a unifying mechanistic explanation. However, patients still have significant suffering, impairment in their quality of life and function. So we sort of start calling these syndromes functional syndromes or idiopathic or diagnosis of exclusion, which are all sort of different ways of saying we don't really know. And it's often very frustrating to patients because they hear that there's no clear cause and we don't really have a cure. It's been very challenging, I think, for both patients and physicians to manage. So what if this is because we are sort of thinking about these syndromes fundamentally in a way that's not entirely accurate? So I want to introduce a different idea. And this is an example of what we call a complex system. So this is an ecosystem. And so how is this different from complicated? Complicated, complex, they sound very similar. Well, complexity in the system sense is characterized by several related concepts. So one, it has many more components than, say, a complicated system. So you can imagine an ecosystem, you have the physical structures, the climate, the various flora and fauna that all interact together to create a dynamic system. These systems often are marked by non-linearity. You cannot always predict what would happen to the rest of the system if you change one particular variable. Let's say you introduce a new species into an ecosystem, you don't actually always know exactly what's going to happen next. There are also internal feedback loops and patterns that arise. So you can imagine certain predator-prey cycles within the system, or symbiotic relationships between plants and animals, or plants and parasites, or et cetera. So this complexity is what really characterizes systems like the economy, weather patterns, ecosystems, and also, when you think about it, the living organism. We are more akin to, we can be more accurately be described as a complex system rather than a complicated one. So what does that mean in terms of actual diseases? Well, potentially, if you take this to this logical conclusion, then many disease processes or disease conditions may actually more approximate a complex system than a complicated one. So I'll give you an example of this. If we take the problem of, if we look at the problem of obesity, we used to think about obesity from a pretty simple perspective, actually. It was calories in and calories out. And if you have too much of one and not enough of the other, you end up developing obesity. So people were told to eat less and exercise more, and it turned out that didn't really work. If it did, we would have solved this problem a long time ago. And then it was thought of more as a complicated problem, so people started thinking about people's metabolism and their genetics and their gut microbiome. And, individual interventions were developed to target those specific areas. However, so far it doesn't seem that has made a big dent on the problem either. So more modern researchers have started looking at this problem and applying a complex systems approach. So this is a kind of a difficult diagram to look at, but this is the result of work from one working group in the UK commissioned by the government to really put together a scheme of all the factors that we've been able to find that contributes to obesity and lay out how they interact. So you can sort of see, or maybe you can't, that in the middle we have energy balance, but the surrounding groups, you have factors that can be grouped into physiology, individual psychology, physical activity environment, individual physical activity, food consumption, but also the greater food ecosystem, as well as the social psychology of the environment that the patient's in. So, and even within those groups, you have a myriad of different factors that all sort of interact in what we call complex ways. So a lot of groups are proposing that this is really the way to start understanding these complex diseases. And only through using this and finding interventions that can effectively be used in this sort of schema can we be more, can we achieve more progress in treating this very important problem. So the quote from one of the papers that look at this says that a reductionist approach towards treating obesity as a simple problem has had little effect in reducing obesity trends. And I could even replace that simple with complicated, and it would pretty much have the same effect. And you can sort of imagine replacing obesity with many of the other common health epidemics that we're seeing, such as diabetes, metabolic disorders, addiction, chronic pain, etc. So another quick example that I want to give is that of the stress allostasis response. So this is work done by Dr. Bruce McEwen, and this is the concept of how the physical organism is able to respond to stress, or any kind of physical, environmental, or psychological stressor. And the idea is that your body will use its physiologic mechanism to maintain its homeostasis in the face of a challenge from wherever. And the idea is that if you accumulate enough of this allostatic load, it can have negative impacts on the health of the organism and lead to a variety of different disorders. And each person or each individual has its own sort of reserve that is able to resist the damage from allostasis and allostatic load. And so that's termed the homeostatic reserve. And we all sort of intuitively get this. You know, if you have a patient in the hospital who is extremely frail, has been hospitalized multiple times, has had a prolonged hospitalization, you just know they have less homeostatic reserve than a young, healthy person with the same condition. So the way that this system has been thought of is, again, as a complex system. So between the perceived stress and your physiologic response, there are these myriad variables that all interact to facilitate the actual response. So you have your environmental stressors, life events, history of trauma, which you can imagine has a wide range of possibilities. Individual behavior responses, patterns of thinking, genes, development, experiences, all of these things sort of interact with the particular stressor to determine what the physiologic response would be. So for example, I'm not particularly experienced at giving grand rounds, so I probably feel a little more allostatic load than, say, Dr. Kubak, who's been doing this for many years. And it's also nonlinear in that the same stressor at different amounts can be protective or detrimental. So if you are training for a marathon and you've done incremental training and then you run a marathon, you're going to feel much less allostatic load than somebody who's walking off the street and decides to join, let's say, the Boston Marathon. So you can either lead to adaptation or allostatic load. And when the allostatic load reaches a certain amount and overcomes the homeostatic reserve, then individuals are at risk for a variety of different illnesses, such as cardiovascular disease, cancers, metabolic syndromes, et cetera. So all of this is well and good, but how do we actually use this as individual clinicians? Because that's ultimately, I think, the issue that preoccupies most of us. I can't really go around and change what people have experienced or reverse their childhood traumas, nor is it that simple to ask patients to engage in behavioral change. It's actually extremely difficult. So is there a model or some tools that we actually can utilize as clinicians to help treat patients who have complex illnesses? Well, it turns out, as Dr. Fogelman alluded to, Chinese medicine has been doing this for thousands of years. So when Western medicine has been thinking of the body as more akin to a machine-like process, Chinese medicine and a lot of Eastern medical traditions have always thought of the body as a garden. So I will now turn it over to Dr. Shubov to explain more about how this occurs.
First of all, total pleasure and honor and privilege to stand here. Thank you for the wonderful introduction, but also just the privilege of standing here and for us to be able to try to explain these things, these kind of esoteric concepts of thinking the body as a gardener would treat a garden in front of a room of high-powered intellectuals in Western thought is really quite astounding. So as Annie has described, a complicated system, complex system is not really something that really lends itself to the kind of medicine that we understand through medical school, through residency, and through all our entire careers. So let's try to break this down into things that we used to know before we went to medical school and things that are largely considered to be obvious. Kind of turn on this part of our brain that we've somewhat neglected. This idea of homeostatic reserve. How do we use the idea of homeostatic reserve in a way that's familiar to us? So let's take an example of somebody that we think of as having a lot of homeostatic reserve. This guy has so much homeostatic reserve that it takes quite a bit of change in his environment to knock him off kilter. How much homeostatic reserve does he have? He is so imperturbable that his name is the Rock. Okay. So what happens if we put him in a cold environment? Thank you. So not very much happens to him when we put him in a cold environment. His temperature doesn't really drop. How does he maintain homeostasis? Well, in some circles, you can use the term that he summons this invisible aura of protective energy to defend him from the outside elements. Of course, in this room, we don't use those terms. We say that there is an involuntary heat transfer that occurs between his skin and the skin and the air around him to create a layer of thermal energy that just buffers his internal heat from the outside elements. Simultaneously, he shunts his blood to the inside to protect himself. But for all intents and purposes, it also kind of fits to just generally blur the lines and say that there is some kind of a defensive mechanism that comes up. And when you compare it to maybe a standard office worker, they can also do something similar, but maybe not quite as impressively so. And if you go further and say the senior citizen will also try to mount the same response, but intuitively we kind of understand that the person on the right may not necessarily survive as long in a cold environment as the person in the middle. A couple of questions come to mind. One is, how do we know this? Are we just being judgmental? We could be. Is there any physical exam finding that we could say to predict that the person on the right is going to succumb to hypothermia first? Is there maybe their internal temperature is the same when they walk in? Is there a lab result, or is there an imaging study that we can use to predetermine how long this person is going to survive? Seems kind of obvious, but there's not really any kind of objective measure that we have. The other question is, how would we advise these people to survive? Well, the first, besides the obvious thing, which is bring a coat. And the way that a coat works is by adding an additional protective layer against the outside. But beyond that, cultures time immemorial have known that there are certain foods that are helpful in the cold environment. In general, in the wintertime, we generally think of Thanksgiving or this Christmas dinner as being heavy in meats, heavy in stews, soups. And we wouldn't really intuitively say that you should advise the person on the right here to eat a salad of mint and cucumbers before going out to the cold. How do we necessarily know that that means anything? It's not really clear. We don't have any mechanism that we've learned about to explain this. Why is this important? Is because the cold is not really something we deal with in California, but infectious disease, the same metaphor can be applied to infectious disease. When introduced to a bacterial pathogen, the same kind of system applies, that there are some people that will succumb to the bacteria sooner than others, and you can imagine the person in the middle may have a larger homeostatic reserve and be able to mount a stronger response than, say, the person on the right. Incidentally, in Chinese medicine, this can be measured in terms of the strength of their fever. So a high fever of 104, while septic, predicts a relatively robust clinical response. The person on the right, you may expect would mount a relatively small fever in response to sepsis and possibly even become hypothermic, which we all recognize is a bad prognostic indicator. Incidentally, on the other side of things, in pediatrics, we'll know that kids actually mount such a high fever that they may develop a seizure. We've known this for a long time. Back before we fully understood the pathogenesis of tuberculosis, we knew that tuberculosis was a disease of malnutrition and poor socioeconomic status. And those that walked among us, among them that had maybe the doctors that had a higher nutritional status and socioeconomic status, had a higher protection from this disease. And so all of the advances that we've had in the last 100 years to identify how this protective mechanism works by understanding T cells and B cells and complement cascades and all the way down the chain, it's kind of distracted us from what we used to know a long time ago. This becomes important because there's still plenty of diseases that don't really have good antibiotics for, and we still have to maintain, we still have to find a way to combat against them. And our protection from these diseases is essentially the same thing as limiting ourselves to being able to put on a warm coat in a cold environment. But we don't necessarily have the tools to support the host immunity in the same way that kind of the older cultures used to. That's all. So let's switch gears a little bit to talk about a different kind of a pattern, one that maybe helps to explain functional disorders a little bit better. And how, before modern scientific method, which was developed relatively recent in human culture, people developed medications, drug therapies, herb therapies, interventions based on the subjective exploration. They would take an herb and feel how it feels. And so I'd like to invite you guys to, right now, just get a sense of the subjective feelings of your body and feelings of your presence right now. And I'm going to tell you a story that's going to elicit a response in your body. And I'm going to ask you, with audience participation, and you guys are going to be a little bit louder this time than earlier, about some words that come to mind when we tell the story. So for a moment, let's just get our somatosensory cortexes turned on, get our frontal lobes turned off. Let's pay attention to the present moment. We'll do so by just recognizing something we tend to take for granted, that we're breathing right now. Just pay attention to the fact that we have a breath, maybe that our chest may be expanding. Abdomen's maybe expanding. Maybe put your feet on the floor, flat. And I'd like you to bring your attention to your hands, because we have a lot of nerves in our fingertips. The homunculus is humongous around the hands. Just see what kind of sensations you could feel from the fingertips, from the hands. Maybe you may be able to tell the temperature of the room. Maybe the touch of your clothes if your hand's on your lap. Now that we're more present, remember the last time you remember being on call in the ICU. Let's pretend it's the late afternoon. The night team from the night before has just signed out their pager to you. You're in charge. They've left you a sign out. You're not the happiest with their sign out. They've had some issues with patient handoff in the past, but you think you'll manage. And that's not really in your field of vision right now, because there's a patient in front of you that was admitted this morning who is increasingly septic and his blood pressure is dropping, and you know that you have to put in a central line. You just got off the phone with family members. It was a very difficult conversation, but you were able to obtain consent to proceed with the central line placement, and you just received report from the ER that there's a person being transferred up as soon as they're stable, and you're worried that you have to stabilize this person before the other person comes in. At that moment, the nurse pulls you aside and says, "Doctor, the patient in room 12 is requesting a shot of IV Benadryl to go with the IV Dilaudid." You look at the sign out, and all it says is, "Do not give IV Benadryl." You'll put that aside for later. You get ready, you walk into the room, you open up the central line kit, and you get a page, an urgent coding query to please addendum your last discharge summary of a patient you have no idea about to specify the degree of protein-calorie malnutrition. Shout out some sensations that you felt.
Frustration.
Where? Frustration. Where? Did anybody feel frustration somewhere physically on the body? In the hands? Probably not. Any other things that were said, that were felt? Anybody feel tense? Like physical tension? Where physical tension? Stomach. Does that physical tension in the stomach is associated with any other kind of butterfly feeling? What about heart? Did anybody's heart change? Anybody? Sorry? Increased heart rate. Thank you. What about any neck and shoulder tension, or kind of tension up in the neck and shoulders, or anything else? Anyway, there's this feeling of something that happens that seems to affect a lot of different organ systems: heart, gut, frustration. I will suggest to you, leadingly, that there's some tension in the neck. We tend to use this word that comes out of Chinese medicine that was translated, and it actually seems to describe this idea of stagnation, meaning that if you have a normal flow of muscle tension, or if you have a normal flow of anything, that flow stagnates, and that can be applied in the terms of the stagnation leading to spasm. And if we can kind of understand this a little bit better, it would help to move forward. So in the musculoskeletal system, the idea of stagnation and leading to spasm makes sense. If you stagnate, if your muscles generally go from a loose, relaxed environment to one of tension, then your axial muscles tend to become hypooxygenated and can spasm up in your neck, your lower back, and your shoulders. If your neck becomes tense for a long period of time, you can end up pulling on the dura and the scalp, cause a tension-type headache because those structures attach in the brow, and so you may end up with a kind of referred myofascial pain and what we call a tension-type headache. Cardiovascular system, people will feel a higher heart rate, or maybe even their blood vessels will constrict, increasing your SVR and causing a hypertension. Sometimes even the heart itself will, instead of flowing normally, it will actually kind of spasm and stagnate, and we call this a PVC because we tend to look at it through EKGs. All sorts of things happen to the GI system. So from the start, the stomach can stagnate, so you have slowed gastric emptying. The stomach may also start spasming up, and so you can have the reflux of gastric contents if you have a incompetent lower esophageal sphincter. In the small intestine, if you don't have the peristalsis, then you can end up with the fermentation of gastric products that have been undigested from a slow stomach, and you end up with gas, bloating, and eventually the bacterial overgrowth as you feed all these bacteria that find it a very nice pH-neutral environment to live in. And then moving on into the colon, without normal colonic peristalsis, you end up with constipation. The uterus is affected. If you don't have normal uterine flow downwards, you end up with cramping. And even in our world, we consider endometriosis to be stagnation of the uterus to the point where it is actually refluxing up endometrial contents into the abdomen. Even the genitourinary system can be affected in terms of overactive bladder, which can also be thought of as a spasming of the bladder. So in general, after a night of call, we will go home and rest. But what if the stress is not something that is episodic like that and you don't have a call schedule? Instead, what if your stress follows you home with you, maybe even follows you into your sleep and every environment that you have? You have no way to get away from the stress, and over about a decade or 2 decades, these things progress. Fibromusculoskeletal pain, well, there we go. Diffuse musculoskeletal pain, this is how we think of as fibromyalgia, where the entire axial musculature becomes tense and painful. The chronic tension headaches turn into migraine headaches, hypertension, palpitation, all sorts of functional GI disorders, and eventually just endometriosis and chronic pelvic pain. You may recognize these diseases to be comorbid with each other, and they tend to happen in the same patient. And what happens when we apply a complicated system to these diseases is we have a patient who's on Cymbalta, on Topamax, on beta blockers, on Linzess, on NSAIDs, and on oxybutynin. And when was the last time that you had a patient that was on all these medications and came back to you and said, "Thanks, doctor, I feel wonderful now"? Of course not. We recognize that the first line for all of those diseases is lifestyle modifications. We recommend regular exercise, mindfulness, sleep, equanimity, psychotherapy, CBT. Taken individually, these are all actually complex solutions. These are all complex things that we can do to affect the organism broadly. But it's challenging. It's challenging for us as doctors in a short visit to try to go through this. It's challenging to refer people appropriately to their therapists. But moreover, it's challenging for the patients who are overwhelmed by the burden of disease to actually try to do something additional. So we're left with trying to find an intervention that we can apply to patients, and that's what we like to do as physicians. In general, we like to intervene on their behalf to treat them. And so what do we use in EastWest? We like to use acupuncture. We find this to be a complex solution that is directly intervenable. It's worth it to spend about 10 or 15 minutes to talk about all of the research that's been done with acupuncture and the mechanisms, because there's been a huge amount of effort to try to figure out how acupuncture works, and it's continued to relatively elude us, but it's worth walking through. What I found the most interesting with the idea of reverse engineering an intervention like this, and just take for a moment that we generally think of our interventions as something that's prospectively engineered. We understand a disease pathway in a complicated system. We design a drug or a surgery to intervene upon that, and we end up with a solution. Even though the drug may, later on have worked in different ways, that's kind of how we are set up to understand. When we take a step back and we see something like acupuncture that works on a completely different model, our attempts to reverse engineer it seem to actually mirror back whatever our cognitive understanding of how the body works at that particular era. And acupuncture research started in the 60s, and so this is an interesting example of where modern medicine has gone in the last 60 years. Take, for example, the early 60s, the gate control theory was the first attempt to explain how acupuncture works. The idea is you have small fibers. This is an oversimplified version, but you have small fibers and you have large fibers. Small fibers are sharp, specific pain. Large fibers are the dull, aching pain. And these are different fibers, and they affect the spinal cord differently. And they both affect this pain cell, which can send signals to the brain, but they have opposite effects on an inhibitory cell that's referred to as a gate cell. So the somatic pain will inhibit the inhibitory cell, which leads to an excessive, a potentiation of that pain signal, very sharp pain. Whereas the acupuncture, which stimulates the large fibers, will activate this inhibitory cell, and so you block the pain from actually going through. So you have patients that receive acupuncture, they'll have this dull, aching pain or sensation, and it will be uncomfortable, but it won't necessarily elicit the pain. This is clinically useful when we try to understand the anesthesia that happens with acupuncture, that if, in effect, once this inhibitory cell is activated, then you've blocked the somatic pain from coming through. You have closed the gate, as it were. I find it fascinating that this looks so much like the electrical engineering diagrams and early computer models of the time. But we continue to use this theory in terms of designing TENS units, and even currently this has led to the understanding of spinal cord stimulators, which we continue to expand upon using this model. In the 70s, 80s, and 90s, we got very big into molecular biology and tried to understand acupuncture through that lens. For those of you that are interested in more reading, this is an article that was that very well summarized this in 2014 in the journal Anesthesia about mechanisms of acupuncture. This, incidentally, is the most adorable picture I could pull out of that. It shows that acupuncture points can be mapped out on animals. This helps with standardization, helps with animal research. And there's an animal model of inflammatory pain that they use, where they will inject Carrageen or some other inflammatory thing into the paw of an animal. They will then put a pressure on that paw and measure how long it takes, how much pressure they can exert before the animal retracts its paw. This would be a paw withdrawal latency, and that's an objective measure of pain. They can then put an acupuncture needle in the relevant acupuncture point and partially extend that interval so it blocks the pain. They then will inject an antagonist into the plantar paw and block that acupuncture effect, meaning that if they put naloxone and they find that naloxone partially blocks the effects of acupuncture, then you can suggest that acupuncture operates on the endorphin or opioid pathways. Brilliant. The problem is that this gets more complicated as we experiment with more antagonists. This is an intentionally challenging slide. I want to direct you to this top row. This is the inflammatory pain model, and these are all of the cell signals that have been implicated in the acupuncture research, meaning that if you put adenosine, cannabinoid, COX, interleukin, TNF antagonists, you can partially block the effect of acupuncture, which suggests that acupuncture works upon these mechanisms as much as it works upon opiates, which is frustrating. You could probably figure out a very complicated set of diagrams to link all these things together, but this is only in the periphery. If we then actually leave the periphery alone and we just leave the inflammatory pain in the paw and we only start injecting intrathecal antagonists into the spinal cord, into the CSF, then we also find a similar kind of thing. The opiates actually partially block this, suggesting that there's an opioid pathway, but there's also serotonin implicated, dopamine, norepinephrine, a whole host of other things, some of which we know that by agonizing these in terms of SNRIs, we can actually partially block pain signals, but these get extremely complicated. And to me, this is a failure of the complicated system. This is an attempt to bring a complicated system to a complex intervention, and this is what you get. You get something that's completely clinically unuseful. This doesn't help us in drug design. This doesn't help us in clinical utility. In the 2000s, we got obsessed with brain mapping and functional MRI imaging. This is an example of this shows you the amount of functional MRI images studies that have been applied to acupuncture research over the decade. And in 2012, about 800 functional MRI studies were counted, and this is already out of date. This is probably my favorite slide in all of acupuncture research. This is the kind of slide that the ancient acupuncturists would have died over. This is what happens to the brain under every particular acupuncture point listed. And I'd like to bring your attention to a couple of things. PC6 and PC7. PC7 is right here on the wrist crease on your hand, in the middle in the median nerve, right over the median nerve. PC6 is about 2 centimeters or 3 centimeters proximal to that, meaning that both are in the same dermatome, same median nerve, and both have a local inflammatory effect if you were to put a needle into it. But in fact, you have a control here, and that inflammatory, the intrathecal antagonist and the local antagonist all apply in the same way to both acupuncture points theoretically. But you have all of these activation of central structures of the brain with this and not this. Another thing happens over here: liver 2, liver 3. Liver 2 is in between the web of the first and second metatarsal. Liver 3 is about 3 centimeters proximal. And you can see the pleomorphic effects that happen in the central brain structures here that are impossible to understand or to break down. Incidentally, when you hear acupuncturists speak about how a single acupuncture point is good for sleep and pain and stress and menstrual cramps and digestion, it doesn't fit our mental heuristic of a single drug having a single action. And this is why, and this is an example of how a single intervention can have a kind of a complex set of effects. The somatic autonomic reflex is probably my favorite way of understanding acupuncture, just because it's so simple. It's something that we all understand intuitively. The idea that, although we don't really use it, the idea that stimulating a somatic nerve on the outside of the body can influence the internal autonomic nervous system. An example is vasomotor rhinitis. If you have cold wind on your nose, you end up with a rhinitis that is triggered through the parasympathetic nervous system. In stomach 36, which is probably the most studied acupuncture point, as shown here, in animal models, it increases lower esophageal sphincter pressure, restores gastric accommodation after vagotomy. Let me pause here for a moment. They take dogs, they clip their vagus nerve, and they show that their stomach ceases to accommodate food. They then use this acupuncture point and can partially restore that accommodation, meaning that you have a parasympathetic stimulus that is not vagus nerve dependent. You may remember that the sacral nerve also innervates the enteric. Is another way to use to activate the parasympathetic nervous system, and you can actually measure in animals the activity of the sacral parasympathetic nerve to suggest that that's how this works. This is a study using TENS units, which is a transcutaneous electrical stimulation on that acupuncture point, just to show you that the needle is not necessarily the important part. And just to show you that with two different frequencies, you can either activate the thalamus or the hypothalamus, and you may remember that the hypothalamus is implicated in autonomic balance. In a sense, you can use this acupuncture point as a parasympathetic agonist. And for the cardiologist in the room, I would suggest that this by itself as a standalone therapy is incredibly important and something we need as a medical system. Think about all of the attempts that we have to change the balance from sympathetic to parasympathetic. All of our attempts are basically at reducing the sympathetic nervous system. Beta blockers, ACE inhibitors, clonidine. When it gets severe, we have stellate ganglionectomy, renal denervation, but we don't really have anything to increase the parasympathetic nervous system. We have cholinergics, which don't really seem to do that. We have nitrates, which kind of sort of work on that element, but nothing really to increase the parasympathetic nervous system. Vagal nerve stimulators are something that's emerging that historically have been used to treat epilepsy, but are under investigation for the treatment of all of these things: sepsis, prevention of CHF following MI. Not something that's, you don't exactly want to implant one of these in a septic patient, and so there are very expensive and handheld devices that can be considered that are non-invasive as a way to stimulate the vagus nerve. And what's fascinating, what I like is that these are probably going to be very costly devices, and they happen to be doing all the medical research that we need to do to really justify the use of acupuncture. But something worth considering is maybe using what we already know. Another line of reasoning that's completely separate from all of those things is the idea of connective tissue planes and fascia. Fascia is an emerging topic of discussion in the medical community. It's something that we know that kind of connects the whole body and connects every muscle tissue, every organ. We generally know about it in gross anatomy as something you cut through to get to the organ that you're looking for, but other systems of medicine treat this more importantly as its own organ. Fascia is organized in terms of connective tissue planes that can go up and down the body. And interestingly, when you draw these lines, there's a significant parallel to what we call in acupuncture theory a meridian. When you put an acupuncture needle into fascia, you actively change the fibroblast cell shape, and the fibroblasts, within a few minutes, expand their cytoskeleton and start secreting more collagen. And eventually, after about 20 minutes, when we remove the needle, you have a drop in tissue tension along that fascial plane. This is interesting because maybe there's a purinergic or an autocrine, a paracrine signaling pathway through a potential space. We know that fascia, when it's tight, can conduct mechanical information, can conduct electrical information. And other systems of medicine have been developed to try to stretch and mobilize fascia. Yoga, physical therapy, and acupuncture all are entirely independent of each other and were developed without any communication, really, of each other. You have South Asia and East Asia, which we would generally say is kind of relatively separate, and physical therapy, which didn't really have much background, well, theoretically, of both of them. Even ideas like some yoga poses that we know may stretch some of these fascial planes. In physical therapy literature, we see this as a lateral line, and in acupuncture theory, this can help us explain why we use points in the foot to address migraine headaches, because they're all on the same fascial line. The other interesting thing, not only that these things were developed independent of each other, was that all three of these things are completely independent of anything that we know. We're doctors. We work in this hospital. We generally have never been taught about physical medicine. At least here on the West Coast, physical medicine rehabilitation is not really something that's well represented, but something we may be able to learn a lot from. So I've offered you a lot of explanations for how acupuncture can work. But is it useful? Can we come away from this saying that, oh, I understand how acupuncture works? Well, not really. These are multiple complicated systems, complicated ways of understanding kind of analytically how acupuncture works, but it doesn't necessarily lead us to any intervention, with the exception of what I would consider that somatoautonomic reflex. So for a moment, let's consider this is a little bit different. Let's consider a different idea. Let's invent a construct of chi, of energy that needs to flow through the body, and when it doesn't flow, you end up with local dysfunction. You have local dysfunction if it doesn't flow locally, and you end up with systemic dysfunction if it doesn't flow systemically. So in the example of a call night, we had systemic stagnation, and that leads to systemic dysfunction, and acupuncture relieves the stagnation of chi in this construct. To me, this is a more helpful tool, knowing, even though we don't have to necessarily convince ourselves that chi is a measurable thing. So how effective is this? There's actually been quite a bit of human data. There's been now 20 or 30 years of randomized controlled trials. I'm going to list the best studies that I've seen. I'm going to kind of go through this relatively quickly. The Cochrane review for fibromyalgia showed low to moderate level evidence that compared with no treatment or standard therapy, acupuncture improves pain and stiffness in people with fibromyalgia. However, there's moderate level evidence that the effect of acupuncture does not differ from sham acupuncture in reducing pain. So let's talk about placebo. We can't have a conversation about acupuncture without openly discussing placebo effect. Placebo effect is huge for everybody, for pharmacotherapy, but it's bigger for acupuncture. And there's this paradox that even though acupuncture may be more effective than medication, it's not as effective always. When we compare acupuncture, when you compare medication to placebo and you compare acupuncture to placebo, you have a lower effect size of acupuncture. Let me do that again. If you have a 50% response rate to acupuncture and you have a 40% response rate to medication, but you compare acupuncture to placebo and medication to placebo, you end up with a larger effect of medication compared with acupuncture. Let's break this down. Medication has a 41% response rate. Placebo medication has a 22% response rate. You have about a 50% increase. Acupuncture has a 51% response rate, whereas placebo acupuncture has a 38% response rate. So actually, placebo acupuncture is as effective as medication in this example, and if we compare these two, then acupuncture may be more effective. But all we do is when we remove, we end up with studies that look like this, and it's very, very frustrating. We all know in the studies that we look at, it takes a huge amount of power to actually resolve this difference in a clinical setting. It takes hundreds or thousands of patient examples to be able to see the difference between acupuncture and between medication and sham medication. And that's in the setting of a usually well-funded study of medication, and it's very challenging to provide the same thing with in an intervention that is fundamentally harder to study, to fund large-scale studies for. And so you're going to find this over and over again, that acupuncture is no more effective than sham acupuncture because the effect sizes, the sample size is not large enough. That said, there are ways, if you do have a large enough sample size, you do see a difference. This is a Cochrane meta-analysis that included 40 randomized controlled trials, about 5,000 participants, and they were able to show reductions in postoperative nausea, vomiting, and need for rescue antiemetics with stimulation of this acupuncture point. Back to the migraine headache, the Cochrane review suggests available studies. Acupuncture is at least as effective or possibly more effective than prophylactic drug treatment and has fewer side effects. If you look at the forest plot, you see this is acupuncture versus nothing, acupuncture versus medication, and again, acupuncture versus sham is not quite as impressive as acupuncture versus medication. This is challenging. Functional GI disorders, it's worth kind of expanding upon functional GI disorders. Gastroparesis, this is a systematic review. This forest plot for gastroparesis versus acupuncture versus domperidone versus cisapride versus mosapride. And in general, you can see that it's helpful. This bottom one here is a very small study of electric acupuncture versus sham. I wouldn't necessarily give too much credit. Functional dyspepsia, Cochrane suggested no difference between acupuncture and medications, which is not a null finding. It's actually very important because we have a lot of patients that have gastroparesis resistant to medications. GERD, there's a really fascinating real-world RCT. What happens when we have a patient who has GERD and refractory to PPI? We double the PPI. There's not a lot of evidence to suggest that that's what we should do, but that's what most clinicians will do. So that was the control group compared with acupuncture. And when we measure their symptoms daily, acupuncture plus PPI group had improvement in all measured outcomes, whereas the doubling the PPI alone had improvements for symptom of daily heartburn alone. This makes sense from a sympathetic nervous system perspective as well, if you want to just think about it in terms of the autonomic reflex. That acupuncture point, so stomach 36 was used. Acupuncture versus, this is the data for IBS. These are data for acupuncture versus pharmacologic medication versus bifidobacterium versus psychotherapy versus psychotherapy, acupuncture plus psychotherapy versus psychotherapy alone, acupuncture plus another Chinese medicine intervention versus that intervention alone, and acupuncture versus no specific treatment. But then when you compare acupuncture versus sham, you have kind of more of an equivalent, maybe trend towards positive. What kind of sham acupuncture is effective in IBS? Actually, Ted Kapchuk, who is one of the more famous acupuncturists, who now leads the Institute of Placebo Studies at Harvard, conducted a study where he compared limited sham acupuncture to what he called augmented sham acupuncture in patients with IBS. A limited sham acupuncturist would walk in, introduce themselves, say, I'm going to do acupuncture for you, and then do fake acupuncture for them. An augmented interaction would be an acupuncturist who would walk in, spend 45 minutes discussing the impact of IBS on their quality of life, and then ponder look at their tongue, feel their pulse, and then ponder for 20 standardized seconds what their treatment's going to be, and then do fake acupuncture on them. And you can see that the augmented group did significantly better in goal of improvement, adequate relief, symptom severity, and quality of life. I bring this up because this has nothing to do with acupuncture. This is the doctor-patient interaction by itself is a complex intervention that is therapeutic and something that we can all do today in our clinics. But what's the EastWest approach? We'd like to break it down into three major events. The consultation is when we try to reduce this long list of diseases that the patients have to one or two major processes, hopefully that is within their control. We then apply a treatment, either acupuncture, trigger point injection, something in the clinic so that we can show people that they are capable of feeling better. Then in the best case scenario, if we have success, we empower and coach the patients to maintain this feeling of better through lifestyle modifications, and this is the same lifestyle modifications that we discussed earlier. So who is EastWest? We currently have 4 clinic sites, 10 full-time doctors, 10 acupuncturists, 3 fellows, 25 administrative staff, increasing patient population. We're seeing about 30 or 35,000 patients per year now. In July, Annie and I started an inpatient consult service, which we're very excited about. We've been able to actually bring this system of medicine into the hospital where it's kind of needed the most. Currently, we're only at Santa Monica Hospital for now. And at the same time, we joined the extensivist program to try to capture the highest utilizers of care, the people that are genuinely refractory to the medical tools available to us. So I'd like to leave you with this idea that the 20th century understanding of medicine that we grew up in, that involved these complicated systems, is about to get much, much more complicated. All the grand rounds that have come before us and are about to come are going to describe how this is going to happen. These diagrams are about to get much, much more complicated, but also the data points we're going to be able to fit into these diagrams are going to get more complicated with genome sequencing, proteome sequencing, microbiome sequencing. It's going to rapidly outpace the ability for our measly human brains to understand and comprehend, and we're going to increasingly rely on machine learning and artificial intelligence to help compute this and guide us to the extent of complicated systems can guide us. Hopefully, this will lead to an explosion in medical care and success in treating a huge amount of diseases that are currently untreatable. The paradox is that as these diseases are treated, they're going to be removed from our population. And we as doctors are going to be left with only the things that by definition will not respond to this line of reasoning. In a sense, we need a new operating system to understand the complex understanding of how the body works. Fortunately, as humans, we are actually uniquely adapted to do this using things like abstract thought, things like doctor-patient interaction, and if we choose to do so, tools like acupuncture, all of which we're going to do better than machines for the foreseeable future. So the irony is not lost on us, but it's fascinating to think that systems of medicine that were developed thousands of years ago may actually end up becoming more effective as systems of medicine to lean to for diseases, complex diseases of the future. Thank you all for your time and attention. We're happy to take questions.
Thank you. Annie, you want to come up? Who wants to start the discussion? Harry Green.
I found it very interesting. How do you do sham acupuncture?
There's several, the question is how do you do sham acupuncture? There are several mechanisms. One involves a telescoping needle that retracts into the hub of the needle, so there's no actual needle puncture. Another involves true needle puncture of the skin, but at points that are next to it. There's, with the TENS studies, you have electrical pads that may or may not send electricity through. It's been a problem. It's been a difficulty trying to study sham acupuncture, but when we use those things, it seems like the sham intervention is effective. And if you unpack what happens in a sham placebo study, there's a lot of effective components of it that we can't really blind away. So things like asking a patient to consider their disease for 20 minutes in a dark, quiet room with music playing is something that is not a null treatment. That is helpful, especially for people that are suffering from diseases like chronic migraines and stress-related allostatic load issues. So it's been challenging.
Kit Huey, and then Jim Weiss.
Hi. Well, the student is much better than the teacher. I applaud your presentation. I think I just want to mention that the NIH is no longer funding sham acupuncture because if you understand the fascia idea, then when you stick a needle into a place, it would have like effect already. So what you're comparing between sham and also supposedly specific point that you use to treat the disease, you're comparing two set of points for specificity. So that's the reason why I think that it's not really useful to study sham acupuncture, but to study acupuncture compared with comparative effectiveness study with other approaches.
That was really terrific. Thank you. I'm struck by the comment you made about artificial intelligence and machine learning, and how that is proven in the computer world to really be the to solve problems involving complex systems, which certainly, as you pointed out in the beginning, is the human body in the same way. But for example, the computer speech, computer vision, all have failed when people have tried to use the reductionist logical symbolic approach and break down components of speech into different things, as opposed to just empirically having a large enough training data set to find patterns there that didn't exist before. And that's how, all of the things we see now with automatic, autonomous vehicles and speech recognition, all of those things work. And your last comment is fascinating to me, is the idea that if you had a big enough data set and you could monitor enough physiological processes going on in the body, could you use machine learning algorithms to recognize patterns that would be able to predict how different points in the system affect, responses in other areas. And it may be that that's really what thousands of years ago acupuncture has kind of been doing, is this empirical approach that, has a phenomenological concept like qi, which you can't define in molecular terms, but is really the emergent property that is a way to understand how there's reaction. So I was fascinated by your talk. Thank you.
Thank you.
I was just wondering, pragmatically, in terms of insurance reimbursement, a lot of the studies that you show seem at least as robust as certain meds that we use all the time and are reimbursed by insurance. Are acupuncturists and EastWest medicine, how is it reimbursed by insurance companies, and have there been issues in that arena?
Insurance generally does reimburse for acupuncture, give or take. The problem is Medicare. Medicare does not, but most private insurances at least categorize acupuncture and will reimburse it based on the deductible and plan that people describe. But something like Medi-Cal, for example, has been covering acupuncture for 40 years, and a lot of the larger studies that are adequately powered were actually done by the NHS in England, which has a kind of a better view on this to try to explain, to try to use this. But it's growing. It's not quite there. The example is inpatient acupuncture has never been insured, so we just don't charge it. We make it work, but it's not. The people that matter need to know this. I agree. I think especially as it comes to these phenomenally expensive interventions that we're about to recommend to patients, you'd think that this would be a relatively inexpensive thing to do.
Hey, Andrew and yeah, this is Roger. So, thanks for the presentation. Actually, I liked it a lot. So, Andrew, you kind of talked about sort of a holistic approach, or both of you talked about a holistic approach in terms of physician counseling, then the acupuncture, and then how you can sort of modify their lifestyles and all this stuff. Because in Western medicine, it's mostly we give a medication, we see the effect, and we see it right there. You talked about the meridians, and the acupuncture. So have you guys thought about, so going to that approach, yes, you provide acupuncture to help out with the meridians. What about acupressure? Say if you teach patients going home and actually have them do all these different, pressure points where they can actually help themselves out so that they can actually optimize their own health in that regard. So that's my first question. The second question also is acupuncture. In Western medicine, we're so used to prescribe one medication and we see the effect. With these treatments that you have, how many sessions are you able to do so that you can sort of kind of see some effect where some patients really want to see immediate effect, and how do you resolve that?
I'll be mindful of time. Now, let me respond with the second question first, is how many treatments of acupuncture does it take? I think actually this is where EastWest differs from a lot of traditional acupuncturists, that we don't recommend a course of 10 treatments or 8 treatments for knee arthritis or whatever that is. I try to describe, the idea of acupuncture is used as a leverage, as a way to get the patient to believe that they can feel better, and then to try to promote them to do lifestyle modifications that we all know are going to be helpful. And of which, one of the things that we do recommend is acupressure as a way to self-stimulate these acupuncture points. Hopefully, eventually, patients, if they find that acupuncture, when they come to an acupuncturist or they come to see us, they leave feeling better, then they may be motivated to try to create this same response in themselves. And that's when we teach them how to use these acupuncture points using their own hands, and they have access to their hands all day long. And the more they do that, the less we need to see them, and the more irrelevant coming to see us in clinic becomes. So in a sense, yes, we definitely need to use that. Acupressure is a very helpful tool, not only for the non-specific physiological effects that are probably similar to that TENS unit study that I showed, but also, I mean, incidentally, just the placebo effect of a time to take their medication, time to take care of themselves, and they do so in a nurturative environment. And yeah, it can be very, very helpful.
Thank you very much for a wonderful grand round.